Welcome to this video on acute renal failure, designed for providers at all training levels. We will use a case-based approach to explore the fundamentals of acute kidney injury, gradually building depth that remains relevant for senior clinicians. We will examine the kidney's vital roles and what happens when those functions are compromised. Let's meet our patient, a 68-year-old man presenting with 3 days of decreased urine output. He reports fatigue, nausea, and mild confusion, following an illness involving vomiting and diarrhea. His labs show a significant rise in creatinine and elevated potassium, setting the stage for our clinical reasoning process. In this video, we have several learning objectives. We will define acute kidney injury, categorize it into prerenal, intrinsic, and postrenal causes, and explain how the kidney's defense mechanisms shape laboratory findings. We will also learn to differentiate between prerenal azotemia and acute tubular necrosis. We will continue our learning by calculating fractional excretion of sodium, or FENa, and using urine sediment to localize injury. We will cover imaging requirements, signs of uremia, and management strategies, including fluid balance and nephrotoxin avoidance. Finally, we will review urgent dialysis indications and common complications. Looking at the history, our patient faced a viral illness leading to volume loss. Critically, he continued using ibuprofen for pain during this time. His reduced urine output, combined with systemic symptoms like confusion, provides early clinical clues regarding a rising toxic load and potentially multiple underlying causes. Reviewing his medical history is essential for our reasoning. He has long-standing type 2 diabetes and hypertension, and a history of benign prostatic hyperplasia. His medications include an ACE inhibitor and recent NSAID use, while his social history notes he lives alone. These factors are all key pieces of our clinical puzzle. On physical exam, signs of volume depletion are present, including low blood pressure and dry mucous membranes. However, we also find a palpable, tender bladder, pointing to urinary retention due to his enlarged prostate. His lungs are clear, indicating he is not suffering from volume overload. The KDIGO criteria define acute kidney injury based on specific changes in creatinine or urine output. It is important to remember that creatinine is a marker of filtration, but these estimates assume a steady state. Therefore, we do not stage AKI by GFR while the patient's creatinine levels are actively shifting. Acute kidney injury is common and often associated with increased mortality in hospital settings. It is frequently reversible, making early recognition vital. By hunting for the specific insult that preceded the rise in creatinine, we can significantly improve patient outcomes. Recall the 5 essential jobs of the kidney: filtering blood, regulating volume and blood pressure, activating vitamin D, producing erythropoietin, and balancing minerals. When kidney function fails, these processes are disrupted, leading to the clinical manifestations we observe in our patients. When analyzing acute kidney injury, localize the problem to one of 3 categories: prerenal, where blood flow to the kidney is compromised; intrinsic, where the kidney's filtering tissues are damaged; or postrenal, where urinary outflow is obstructed. Identifying the specific bucket is critical for effective management. Prerenal injury occurs when the kidney is, quote, thirsty, either from true volume loss or effective volume depletion. The kidney attempts to defend blood pressure by reabsorbing sodium and water, which increases the BUN to creatinine ratio. Promptly restoring blood flow can allow a healthy kidney to recover completely. Intrinsic injury, such as acute tubular necrosis, occurs when the filter itself is damaged by ischemia or toxins. The broken sieve allows sodium and BUN to leak into the urine, lowering the BUN to creatinine ratio. Unlike prerenal states, intrinsic damage does not resolve immediately upon volume resuscitation. Postrenal injury is caused by an obstruction in the urinary plumbing, such as an enlarged prostate. This back pressure stalls filtration, leading to issues like hydronephrosis. Since this is a reversible cause, identifying and relieving the obstruction promptly, often with a simple catheter, can restore function. In our patient, we see all 3 mechanisms at play: volume loss and medication effects for prerenal, potential tubular toxicity for intrinsic, and an enlarged prostate for postrenal. His pre-existing diabetes and hypertension provided little reserve, highlighting the complexity often found in clinical practice. Once you have identified acute kidney injury, the KDIGO staging system helps quantify its severity. Base your staging on whichever marker is worse, the serum creatinine or the urine output. Higher stages are clinically significant as they correspond to increased mortality and longer hospital stays for our patients. Clinical presentation varies widely. While mild cases are often silent and only caught on routine lab work, more severe injury can manifest through volume disturbances like edema and shortness of breath, or uremic symptoms, including nausea, fatigue, and confusion. Don't forget that bladder symptoms point specifically to a postrenal obstructive cause. Uremia represents the systemic effects of accumulated toxins that the kidneys are failing to clear. These span multiple organ systems, including the neurological, cardiovascular, and hematologic. Recognizing these patterns, like the metallic taste, asterixis, or pericarditis, is vital for identifying when kidney failure becomes a life-threatening emergency. Following a systematic diagnostic approach is essential. Start with a thorough medication and history review, then move to assessing volume status and vitals. Follow this with urine and blood studies to characterize the injury, and use imaging to rule out obstruction. If the cause remains unclear, pursue advanced diagnostics. The BUN to creatinine ratio is a classic tool for distinguishing prerenal from intrinsic injury. A ratio of 20:1 or higher often suggests a prerenal state, as the thirsty kidney avidly reabsorbs urea. Conversely, a lower ratio in intrinsic injury reflects a damaged tubule's inability to concentrate these waste products. Measuring urine sodium helps determine if the kidneys are hoarding salt. In prerenal states, the kidney aggressively retains sodium, resulting in low urine concentrations. In contrast, an injured intrinsic kidney often, wastes sodium, leading to higher levels. Note, however, that diuretics can mask these findings by artificially increasing salt excretion. The fractional excretion of sodium, or FENa, remains the gold standard for distinguishing causes when history is unclear. It calculates the percentage of filtered sodium that is eventually excreted. While highly reliable, remember that it is most useful in oliguric patients and can be misleading if the patient is on diuretics. Analyzing urine sediment is akin to looking at a biopsy under the microscope. Granular muddy brown casts are hallmark findings of acute tubular necrosis. Meanwhile, white blood cell casts point to interstitial inflammation, and red cell casts suggest glomerular bleeding. These findings provide immediate clues to the specific underlying pathology. Imaging is crucial to rule out reversible obstructions. A renal ultrasound is the primary choice, as it is non-invasive, quick, and radiation-free. It can easily reveal hydronephrosis, the dilation of the collecting system, which suggests a blockage. If stones are suspected, a non-contrast CT scan is the next diagnostic step. Risk stratification involves identifying who is stable and who requires immediate intervention. Beyond the immediate crisis, recognize that an AKI episode may cause lasting kidney damage. Recovery from tubular necrosis can take weeks, during which the patient remains vulnerable to complications like volume overload and electrolyte imbalances. Foundational management requires two priorities: treating the underlying cause and protecting the remaining kidney function. This means restoring perfusion through judicious fluid resuscitation, eliminating nephrotoxic insults, and dosing all medications for current kidney function. Always avoid over-resuscitating, which can lead to dangerous volume overload. Tailor your management to the specific mechanism of injury. Intrinsic injury usually requires supportive care and time. Postrenal obstruction demands swift mechanical relief, such as catheterization or stenting. Throughout this process, vigilantly manage systemic complications, particularly life-threatening hyperkalemia, which requires urgent correction. The AEIOU mnemonic summarizes the urgent indications for starting dialysis: acidosis that is refractory to treatment, severe electrolyte disturbances like dangerous hyperkalemia, specific intoxications, volume overload resistant to diuretics, and symptomatic uremia. Dialysis is a tool to manage these specific, life-threatening complications, not just a response to a single lab number. Avoid common clinical pitfalls by always checking for obstruction, properly interpreting labs in the context of diuretic use, and stopping ongoing toxins like NSAIDs. Never ignore signs of high potassium and ensure all drug dosages are appropriately adjusted for the current GFR. Finally, never assume high creatinine is chronic without reviewing the patient's baseline trends. In our patient, the plan combines immediate relief for his obstruction and volume resuscitation with ongoing medical management. We will monitor for post-obstructive diuresis while addressing his hyperkalemia. This comprehensive, mechanism-focused approach gives our patient the best chance of recovery and long-term renal health. Let us summarize with 5 key takeaways. First, always localize acute kidney injury to prerenal, intrinsic, or postrenal, as this directs all management. Second, remember that prerenal states show high BUN to creatinine ratios and low fractional excretion, which acute tubular necrosis reverses. Third, always rule out obstruction as it is potentially reversible. Continuing our summary, fourth, use KDIGO criteria to stage the injury based on creatinine and urine output. Finally, dialyze for refractory acidosis, severe electrolyte issues, toxic ingestions, fluid overload, or symptomatic uremia. These 5 points serve as a framework for addressing acute renal failure in your practice. This topic connects directly to the next video in our series. You will find a link to the related video on your screen, as well as in the description below. Thank you for watching this overview of acute kidney injury. We look forward to building on these concepts with you in our next lesson.